The topic of today is immunotherapy in head and neck cancer, and I thank you all for staying this afternoon. I'm going to cover the current indications of immunotherapy in head and neck cancer, and what's going on in terms of research and what's coming down the pipeline. I have no disclosures. So the objectives are to discuss the role of immunotherapy and immunology in head and neck cancer, an overview of the current FDA-approved immunotherapeutic agents for head and neck cancer, and the future in terms of immunotherapy. A little background: head and neck cancer is the sixth most common cancer worldwide, with about 60,000 new cases in the US, out of which currently in the last 5 to 10 years, we've seen an epidemic in HPV-related squamous cell carcinoma of the head and neck. This is typically seen in oropharyngeal squamous cell carcinoma, related most likely to the baby boomers and their practices many years ago. So these are patients that will typically present with local regional disease, which leads to a curative intent type therapy with a goal of preserving the organ, improving survival, and cure, which is something that is key to keep in mind, because not too often we get to cure patients in our specialty. About 10 to 15% of the patients will present with distant metastatic disease, so it's somewhat rare in head and neck cancer. And in these patients, the importance is to focus on palliation and quality of life with a focus on symptom management, which is important to bring upon how immunotherapy fits into that. In terms of prognosis, local regional disease have upwards of 50% 5-year survival rate, more so in localized disease, no negative disease. By using a combined modality approach, whether it's chemoradiation, surgery plus chemoradiation, and a topic of discussion year after year is the role of induction chemotherapy with a TPF type regimen. Now, in the refractory metastatic setting, up until recently, even with cetuximab, the survival rate wasn't that great. And with the addition of cetuximab, the improvement was anywhere from 2 to 3 months. Today, the standard of care for these patients in the first line is extreme in terms of the actual chemotherapy regimen, and extreme in terms of the toxicity of such regimen. And we'll talk about where immunotherapy fits into this. So what is the fourth modality? We treat patients with surgery, oftentimes with curative intent and with surgery alone. The addition of radiation therapy to surgery without chemotherapy. Chemotherapy after surgery in combination with radiation therapy or chemoradiation by itself, in the vast majority of the locally advanced patients that get to see a medical oncologist. And the fourth leg to this modality is immunotherapy. And immunotherapy has been approved in the refractory metastatic setting, and as with all specialties within oncology, such as in lung or melanoma, we are looking into moving it to frontline therapy. These are the two drugs that were approved last year by the FDA. Pembrolizumab was approved in August after clinical trial KEYNOTE-12 was performed. Nivolumab followed in November after Checkmate 141 was presented and published at the New England Journal of Medicine, and I'll cover both of these trials and we'll discuss a little further. KEYNOTE-12 was a phase 1b multi-cohort clinical trial, initially with pembrolizumab at 10 milligrams per meter square on an every 2-week basis, enrolling 60 patients, of which all were PD-L1 positive in the initial cohort. Later, it was expanded to 132 more patients dosed at 200 milligrams every 3 weeks, regardless of PD-L1 expression. These patients were treated, again, that 24 months cutoff until progression or intolerable toxicity. And the combined analysis was using both cohorts in patients with refractory metastatic head and neck cancer, PD-L1 positive for the initial cohort, and regardless of PD-L1 expression for the expansion cohort. The primary endpoint was overall response rate, secondary endpoints, response rate, progression-free survival, and overall survival. The key thing here to keep in mind is that the overall response rate was 18%, comparing that to the extreme regimen where the response rate is in the range of 35 to 40%. Not surprisingly, HPV-positive patients had a response rate of 24% versus HPV-negative of 16%. The progression-free survival had a median of 2 months versus, and an overall survival of 8 months. 6 months progression-free survival of 25%, 12 months at 17%, and an overall survival of 12 months of 38%. There was a 60% decrease in the target, in the size of target lesions, regardless of the HPV positivity or negativity, which was quite significant. And the duration of response, the median time to response was 2 months, with 65% of the responders remaining in response when the trial was presented. 24% of the responders had a complete response, which is quite impressive in a non-cytotoxic type therapy. The duration of response was not reached, the median was not reached when the trial was presented, and 71% of the responders had durable response over 12 months. The side effects of Keynote are in line with other immunotherapy agents, which are thyroiditis, a rash, pneumonitis. Important to understand that the grade 3 to 4 AEs were quite low. Nivolumab was Nivolumab conducted the Checkmate 141 clinical trial, which was a phase 3 trial randomizing patients on a 2-to-1 nivolumab versus investigator's choice chemotherapy using methotrexate, docetaxel, or cetuximab in patients with refractory metastatic head and neck cancer of the oral cavity, pharynx, or larynx that had progressed after platinum-based therapy. They were documenting HPV status, and the patients were enrolled regardless of PD-L1 status. Primary endpoint was overall survival, with secondary endpoints PFS and overall response rate. The overall survival at 1 year was 36% versus 16.6%, and the median overall survival was 7.5 months versus 5.1, with a hazard ratio of 0.7 and a p-value of 0.1. The response rate in this trial was 13.3% in the nivolumab group versus 5.8%. Again, compare that to the response rates that the extreme regimen has, which is 35 or so percent. Progression-free survival, a median of 2 months versus 2.3 months for chemotherapy, with a p-value of 0.32 and a 6 months PFS of 19.7 versus 9.9%. Again, adverse events that were treatment-related, similar to that of pembrolizumab, with autoimmune toxicity being the most frequent one, and very low grade 3 to 4 toxicities. ASCO this year had several abstracts in immunotherapy. However, I chose the ones that made it to the oral session. And some of these, for example, the IDO1 inhibitor, ipacadostat, was presented recently by Dr. Hadid. So I'm going to cover that, the cohort of head and neck cancer, which I think was quite interesting. Ipacadostat plus pembrolizumab in head and neck cancer. This was a phase 1/2 results for Keynote 037 presented by Dr. Hamid. So IDO1 is an enzyme that catabolizes the conversion of tryptophan to kynurenine. This is induced by high levels of gamma interferon, and it basically what it does is when, how do I choose the laser? Oh, here, thank you. When we have higher levels of kynurenine, it makes the tumor microenvironment immunosuppressive, and therefore the tumor can invade immunosurveillance. So by using an oral medicine such as ipacadostat, we think that we can combine it with a checkpoint inhibitor and block this, therefore the tumor will not be able to invade immunosurveillance. So Keynote 037 combined pembrolizumab as standard dosing with different schedules of ipacadostat. And I ask for you to focus on your attention on the response rates. So I showed you that the response rates for immunotherapy were in the mid-teens, low 20s. The overall response rate in this group was 34%, with response rate of 27% in the PD-L1 positive, 43% in the PD-L1 negative, and almost 50% in the HPV positive tumor, which is quite impressive just by the addition of this IDO1 inhibitor. So again, remember at the bottom there the 15 to 20% overall response rate in the Nivo-Pembro trials. The percentage change from baseline, you see this waterfall plot at the right side of the slide. Almost half of the patients that responded were CRs with quick responses and durable responses. Responses were observed regardless of the PD-L1 expression. Again, PD-L1 positive in green, PD-L1 negative in orange, both responded to therapy with CRs in both groups. And the treatment-related adverse events were quite similar to that of pembrolizumab alone, with no significant addition of adverse events except for rash, as explained in the melanoma group. So again, hypothyroidism, adrenal insufficiency, and pneumonitis, as seen in the pembrolizumab alone group. In conclusion, this was a safe and effective combination that led to moving this trial now to phase 3 combination in squamous cell carcinomas of the head and neck. The second abstract that I selected was the safety of pembrolizumab with chemoradiation in locally advanced squamous cell carcinoma of the head and neck, presented by Dr. Powell at ASCO. So this was a trial that combined standard chemoradiation. However, it's important to note that standard for them was weekly platinum. And I'll tell you why this was an issue at ASCO this year. So it was cisplatin at 40 milligrams weekly for 6 doses, pembrolizumab 200 every 3 weeks for 8 planned doses, so following even the concurrent chemoradiation plan, and radiation up to 70 gray. So they included patients with squamous cell carcinoma of the oral cavity, oropharynx, hypopharynx, and larynx, locally advanced disease, HPV positive or negative, and patients that were eligible to receive cisplatin. So most of the patients were oropharynx with locally advanced disease, which is the type of patients that we most commonly see in clinic. These patients, the vast majority was able to complete therapy as planned. The ones that discontinued or received less than optimal doses of chemotherapy was supposed to be not related to the addition of pembrolizumab, and almost 80% of the patients received all planned treatment. In terms of chemotherapy, 85% of them received over 200 milligrams per meter square, and in terms of radiation therapy, all completed radiation therapy. In terms of adverse events, there was similar to chemoradiation without pembrolizumab, dysphagia, mucositis, and dermatitis related to most likely radiation therapy. Grade 4 neutropenia, only 4%, and hypophosphatemia, over 4%, again, in line with what we see in clinic currently. Overall response rate, 78% CRs. Altogether, HPV positive tumors did not surprisingly better than HPV negative tumors. In summary, pembrolizumab was found to be able to be delivered safely with weekly cisplatin and radiation in combination. There were no new toxicity signals seen. And this led to a development of phase 2 to 3 trials with this type of approach. Now, I mentioned that it was important to determine why it was interesting that they decided to do weekly cisplatin. There was another trial presented at ASCO this year from Dr. Noronha and colleagues from India, comparing cisplatin at standard dosing, 100 milligrams per meter square on theirs 1, 22, and 43, compared to weekly cisplatin. And the 2-year local regional relapse rate was 38.67% with weekly cisplatin compared to 24% with every 3 weeks cisplatin. This is the first time that weekly cis is combined to standard of care every 3-week high-dose cisplatin. So I think that we can put this issue to rest, that weekly cisplatin has no role in the definitive curative intent treatment of local regional head and neck cancer. In conclusion, PD-1 inhibitors, nivolumab and pembrolizumab, are the 2 FDA-approved therapies for recurrent metastatic platinum-refractory head and neck cancer. The use of immunotherapy in first-line therapy for this type of patients and in combination with radiation therapy is currently under investigation, and most likely we will have data in February in the ASCO Head and Neck Symposium or at ASCO next June. And what I call immunotherapy 2.0, which is combination with chemotherapy, moving therapy first line, neoadjuvant therapy. There was actually one paper with 1 dose of neoadjuvant pembrolizumab, and then the patients were taken to surgery, and the rates of pathologic CRs was quite increased by one of the papers that was published at ASCO this year, or presented at ASCO this year. And again, as I tell you right now, the side note is that cisplatin, it only should be used at 100 milligrams per meter square, and now we have data to support that. I thank you all for your time, and thank you, Dr. Santos, for the invitation.